Ooh, I'm a bit shorter than Rob. Thank you, everyone, and thank you very much for inviting me to be here today. I really appreciate the opportunity to talk to you about the pulmonary rehabilitation guidelines that we have recently published in Respirology. And I think a number of people here. How many people are involved in pulmonary rehabilitation? That is great. I'm going to have to stand up on my tippy toes to be able to see the screen down there, but that's good exercise for me. You can see that by the number of authors on this paper that a lot of people were involved in writing the pulmonary rehabilitation guidelines. And what I'm hoping to do in the next half an hour is just take you through the methodology that we used and also to let you know what our main recommendations were, and then hopefully in the discussion time you'll have time to ask me more detailed questions about what we did. In New Zealand, as you probably well know, COPD, about 14% of adults over 40 years have COPD, and the cost is huge, about $5.6 billion in health, in big picture costs, that's with morbidity as well, but about 484 million in direct healthcare expenditure around hospitalisations. And Maori, 4.4 times higher hospitalisation rate than non-Maori and 2.2 times higher death rate. And if we look at the Australian statistics, they're very similar to those in percentages as well. And so we wrote about this in the guidelines. As Rob just said, pulmonary rehabilitation is a key component of COPD non-pharmacological management, and it reduces symptoms of breathlessness and fatigue, increases exercise capacity, increases quality of life, reduces hospital readmissions and sometimes hospital admissions in people who haven't been admitted to hospital, and decreases length of stay. So some really fantastic benefits from pulmonary rehabilitation. So why do we need guidelines? The American Thoracic Society and the European Respiratory Society have published a statement, but that wasn't an evidence-based guideline. The British Thoracic Society and the Canadian Thoracic Society have produced evidence-based guidelines that are specific for their countries. And in Australia, we developed the Pulmonary Rehabilitation Toolkit, which is very much a how to do pulmonary rehabilitation. It's a web-based resource, and it is based on evidence, but it wasn't underpinned by an evidence-based document as such. So we felt that it was really important to have a guideline that we could use not only to underpin that toolkit, but also in advocacy around future initiatives. At the moment, we're very involved, I'm very involved with the Lung Foundation Australia in trying to get funding for pulmonary rehabilitation in primary care. In Australia, we can only fund pulmonary rehabilitation in hospital outpatients through our Tier 2 funding, but there's no funding in primary care, so it really reduces the ability to have pulmonary rehabilitation more widely available. And we felt that an evidence-based guideline would be important for that. And as you might well know, context does affect delivery. A lot of the studies that we looked at in doing these guidelines were based in Europe. And you can see that Europe fits into Australia pretty neatly. And so you can imagine the difference in density of population, the differences in distances, etc. And so why it would be different for us in Australia and New Zealand. And this morning people talked about the problem with distance in New Zealand as well, and access. And I think that that's an important issue that we wanted to think about as well. So the aim of doing the guidelines was to provide an evidence-based recommendations for the practice of pulmonary rehab specific to the Australian and New Zealand healthcare contexts. So it was quite a big piece of work. We had 28 health professionals, 11 lead people who led different parts of it. We asked only 9 PICO questions. PICO questions being looking at only randomised controlled trials that had a population or patient group, an intervention, a control group and an outcome. And we wanted to think about what would be most important in the Australian and New Zealand context. We looked at systematic reviews for all questions, And we tried specifically, if we thought that we could, to do a meta-analysis of studies that were more specific to how we deliver pulmonary rehabilitation in Australia and in New Zealand. To help our librarians with the search strategy, we used the definition of pulmonary rehab that had been used in the recent Cochrane review by Mccarthy, and that was really in any inpatient, outpatient, community-based or home-based rehabilitation program of at least 4 weeks duration that included exercise therapy. So that was what we used as the basis. We included studies if they were randomised controlled trials or systematic reviews, but they had to report at least one pre-specified outcome of interest, and you can see those ones there: exercise capacity, health-related quality of life, healthcare utilisation, etc. We recovered titles and abstracts of about 17,000 titles and abstracts, which 2 of us in the review had to go through to decide whether to do a full review of the paper. And we reviewed over 242 full papers and included a large number in our study, in our publication, which you can look at your leisure. Each recommendation was rated according to the quality of evidence, whether the quality of evidence was strong, moderate or low based on the grade criteria, and the strength of recommendations were made whether they were a strong recommendation or a weak recommendation. And if we were making a recommendation, we had to consider the trade-off between desirable and undesirable outcomes, the confidence that we had around the quality of the evidence, the values and preferences for patients, and the resource implications. Because although sometimes the evidence might not have been so strong, we felt that it was important the values of the patients might come into it to say that we think this should be highly recommended intervention. So just to give you an idea of how that works, if we made a strong recommendation, for the patients that would mean that almost all the patients would want that recommended intervention. And from a clinician point of view, it would mean that almost all individuals or patients should receive that intervention, and that adhering to that intervention or that recommendation would be a quality criterion that we should be judged by, that we should be able to provide that intervention for those patients. Recommendations are on a continuum. It's not a one or the other, but on the weak end of the recommendation, it means that for patients, most in that situation would want the intervention, but some would not, a substantial number might not, and that we as clinicians would need to be able to recognise that there would be different choices, and we need to work with the patients to help them arrive at a decision consistent with their values and preferences. In some instances, we weren't able to make recommendations and because of insufficient evidence, and we then made an in-research recommendation when we thought that research could clarify the effects of the intervention and that further research would be worthwhile. So what were the questions and the recommendations? So the way I've set the next few slides up is that on the left-hand side is the PICO question that we asked, and on the right, in the middle column is what the recommendation is, and on the right-hand side is the strength of that recommendation. So not surprisingly, we decided we could only ask about 9 questions because you can't go on forever, and we didn't have an inordinate amount of time to do this. And so we tried to confine it to 9 questions that the committee considered were the most important, and we did put these questions before a consumer patient group to also review to decide whether they thought that these were important questions. So the first question was, is pulmonary rehabilitation effective compared with usual care in people with COPD? And not surprisingly, we had 2 systematic reviews that had been recently published in this area, and so we used those as the basis for our recommendation. First of all, in patients with stable disease, the Mccarthy review reviewed 65 papers and certainly we followed suit with that. We did look at programs that were more specifically delivered the way we do in Australia and New Zealand, with at least 2 sessions a week supervised and 8-week programs, but the recommendation was that people with stable chronic obstructive pulmonary disease should be provided with pulmonary rehabilitation, and that was a strong recommendation. As far as after an exacerbation of COPD, in Australia we try and get patients back to pulmonary rehabilitation or first time to pulmonary rehabilitation within about 2 weeks of coming out of hospital. And we looked at a subgroup analysis of studies that randomised people into pulmonary rehab and no pulmonary rehab, and particularly those that went to pulmonary rehab within 2 weeks of an exacerbation. And the data there, which you can see if you want to go and look at in detail at the guidelines, did show that very significant improvement in exercise capacity and health-related quality of life, and a trend to a reduction in readmissions. So not a huge number of studies in that there are only 5 studies, so that's why that recommendation is weak, but still a recommendation that it does make a big difference. What about hospitalisations? Does pulmonary rehabilitation affect healthcare utilisation? So we did recommend that with people with moderate to severe COPD, stable or following discharge from hospital, should be provided with pulmonary rehabilitation to decrease hospitalisations and reduce length of stay. Now, we made that a strong recommendation. You might wonder why that's strong and the other one's weak, but in this one, for stable and post-exacerbation, patients have a strong feeling that they do not want to go to hospital, and therefore if we consider the patient preferences, going to pulmonary rehabilitation we considered was very important to avoid hospital admissions. So I've looked at the people with, in those 2 recommendations, moderate to severe COPD, but what about people with mild COPD? And as Rob was just saying, the criteria in the COPDX guidelines for mild disease is an FEV1 of about 80% of predicted, or above 80% of predicted. And we found that in the studies that we looked at, there were not many studies that looked at FEV1 as a measure of disease severity. So we then moved to looking at mild COPD based on symptoms, which was an MMRC score of less than or equal to 1, which is breathlessness on mild exertion or going up a hill. And we found from the studies that we reviewed that looked at that we could recommend that people with mild COPD should be offered pulmonary rehabilitation. The question is, I think earlier today somebody was saying, I've got so many people being referred to pulmonary rehab, how do we provide pulmonary rehab for so many people? And if you've got a good referral system and you're getting lots of people with COPD, the question is, do people with mild COPD need to come to a formalised program? And I think that's something that we could discuss when we're talking about a little bit later on in the question time. But despite the benefits of pulmonary rehabilitation, only about 5 to 10% of moderate to severe people with COPD participate in pulmonary rehabilitation. And one of the barriers has been cited as transport to facilities. We have pulmonary rehabs in outpatient departments in big centres, but not so many available in the wider rural and remote communities. So one of the questions was, what about the setting? Hospital, outpatient departments, home or community? So we asked the question, is a home-based or community pulmonary rehabilitation program as effective as a hospital-based pulmonary rehabilitation program? And we broke this down to 3 sub-questions really. Home-based as an alternative to usual care, home-based as an alternative to hospital-based, and community-based as an alternative to usual care, which might go towards answering some of the questions earlier about how do we provide this. And the evidence around each of these was enough to make a weak recommendation that home-based could be provided as an alternative to usual care. The thing about home-based is that it needs to make sure that you've got an expert clinician who is keeping good contact with the patient home-based, so that the progression occurs, the intensity of exercise is adequate to achieve the benefits that we know we can get with pulmonary rehabilitation. As far as community-based was concerned, yes, it could be used as an alternative, but again, the frequency, the intensity and the duration needs to be similar to an outpatient hospital-based program, and the clinician needs to be an expert in that area to enable the patients to get the type of program that will make a difference to their outcomes. Structured education. Structured education is a common part of major pulmonary rehabilitation programs. We looked at programs that does a structured education program, enhance the benefits of pulmonary rehabilitation. And the data to date shows that it doesn't make that much difference to the outcomes of exercise capacity, health-related quality of life and healthcare utilisation. So we recommended that all people with COPD, irrespective of the availability of a structured multidisciplinary group education program, could be provided with a pulmonary rehab program. Now, this is not to diminish the value of education at all. It's to say that the types of education that patients receive may not necessarily, being in a structured program, be the best way to deliver that kind of education. We didn't look at self-management education as well, because self-management, I think, is another whole big area. So in this question, it was purely, does structured education make a difference? And the data to date in randomised controlled trials doesn't suggest that it does. And is pulmonary rehabilitation effective in chronic respiratory diseases other than COPD? I don't know about here, but we certainly find in Australia that we are being referred a lot of patients who have other conditions besides COPD, bronchiectasis, ILD, and pulmonary hypertension. So we looked at those three conditions. There had been systematic reviews in each of those conditions recently, and each of those reviews did have a positive effect of pulmonary rehabilitation. The caveats around this are that in bronchiectasis, all the studies also included airway clearance techniques when they provided pulmonary rehabilitation compared to control. And so if bronchiectasis patients come to rehabilitation, one would suggest that clinicians need to be upskilled in airway clearance techniques if they're going to provide those programs. In ILD, the caveat was that those programs should be provided somewhere where there is supplemental oxygen for those who might require supplemental oxygen. And in pulmonary hypertension, the caveat around that was that people with pulmonary hypertension should go to a rehab program where the clinicians are used to managing people with pulmonary hypertension and managing people with comorbidities. So probably not community-based for pulmonary hypertension. Now, there are a number of questions that we couldn't make recommendations for, and these were these. We asked the question, are programs of a duration longer than 8 weeks more effective? This is because most of the programs we deliver are usually 8-week programs, as it has been recommended by statements in Europe and America. What we don't know, and there's some anecdotal evidence that longer programs might make a greater difference to the outcomes of patients. And we went to look at the literature, but we found no studies that compared 8-week programs to longer programs. So we weren't able to make a recommendation due to lack of evidence. What we have written in the guidelines, though, is we did look at the 8-week programs compared to, in randomised controlled trials, compared to no intervention, and they certainly showed good improvements in exercise capacity and health-related quality of life, as did the 12-week programs. So at the moment we can say that 8-week programs are probably effective. We just don't know if we should be providing longer programs or not, because we don't have the data to support that. What about maintaining the gains after a pulmonary rehabilitation program? does ongoing supervised exercise at a lower frequency than you would provide in a pulmonary rehab program, maintain exercise capacity and quality of life out to 12 months. And really, when we looked at the research, we couldn't find an optimal model of maintenance exercise programs. And so we think that the further research needs to be done about what is the best way to maintain exercise capacity and quality of life in the long term. We did make a negative recommendation in a sense, because we did look at programs that did provide monthly supervised exercise, and they showed no greater benefit than just regular review and follow-up. And so we didn't think that we thought it was important not to waste the healthcare dollar, and we recommended that monthly programs should not be offered because the effects weren't significant. What about oxygen during exercise? Interestingly enough, if you look at the data, about 47%, this is one Australian study and a couple of other studies, of the patients with COPD referred to pulmonary rehabilitation who are not on long-term oxygen therapy desaturate during the 6-minute walk test. And often we as clinicians worry about that in clinical practice, and we've provided oxygen during rehabilitation. The issue being that, can you provide oxygen during rehabilitation in all the programs that we offer, and should we? So we asked this question: do patients who experience oxygen desaturation during exercise have greater improvements in oxygen if oxygen supplementation is provided during training? And again, we had to make an in-research recommendation because the data to date, there was uncertain effect around the outcomes in exercise capacity and changes in breathlessness. I do have to put a caveat here. We've just completed a large NH and MRC-funded randomised controlled trial in 111 people who desaturate during exercise, who were referred to pulmonary rehabilitation, which I just presented at the European Respiratory Society conference. And when we did that, we did it around 7 sites in Australia, and we showed no difference in outcomes between those who received oxygen during training and those who didn't. And that was a triple-blind study. We used oxygen concentrators that were blind to the trainer, to the patient and to the assessor, and showed no difference in outcomes of exercise capacity and health-related quality of life. We haven't followed through yet with the hospital admissions for that one. So there were the 9 PICO questions with a couple of other little sub-questions in them. So what was new in the guidelines? There was a recommendation that home and community-based pulmonary rehabilitation could be provided, that people with mild COPD should be offered pulmonary rehabilitation, a clear statement that monthly maintenance programs were not useful, and permission to deliver pulmonary rehabilitation without a structured education program. And please, I really believe that education is important, but maybe we have to think carefully about what form that education takes. And a recommendation for people with other conditions besides COPD, bronchiectasis, ILD and pulmonary hypertension could be offered pulmonary rehabilitation in the right setting. So what do the guidelines mean for patients, clinicians and policymakers? I think you'll see that, and those of us who work in pulmonary rehab believe that there's compelling evidence for meaningful benefits from pulmonary rehab, and so that's a strong mandate to improve access, referral and uptake of pulmonary rehabilitation. But really, to be able to deliver on this, we require multiple strategies. Patients need to have a better understanding of the likely benefits. We know that some patients don't come because they don't think it's going to make any difference to them. Clinicians need to know how to refer and do so more often. We do know that if a GP the GP doesn't make a very positive statement about pulmonary rehab and just says, oh, you might just go along and give it a try, then the patient's less likely to go or to want to take it up. So we need clinicians and referrers to be positive about the responses that patients might achieve with pulmonary rehab. We need to think about how to make programs more readily available and accessible, and maybe that's an important thing when we think about distance, and we've done a bit of work in tele-rehabilitation now. And we want to develop quality standards against which we can evaluate effectiveness to make sure that the programs that are being provided are of high standard and achieving the benefits that we know that programs can achieve for our patients. In our Australian and New Zealand context, I think the weak recommendations for new models of pulmonary rehab around home-based and community-based do have the potential to improve access for people living away from major centres, and some of those studies have been positive. And as I started off in the beginning to say, the disproportionate disadvantage of people, of Indigenous Australians and New Zealanders in relationship to COPD, and how important it is to improve access to pulmonary rehabilitation for these communities. I think in New Zealand you've been much better at this than we have in Australia. I've just started working with Aboriginal communities in Australia, Aboriginal and Torres Strait Islander communities. But in New Zealand there've been one particular study that we reviewed for the guidelines where pulmonary rehab provided by Maori for Maori by Maori organisations improved attendance, and that information and communication in a common Maori language made a big difference to those patients. And I think Rhonda made that point very significantly, and it's very hard to follow those wonderful presentations with something a little bit more with data in it, but I think that she made the good point that that's very important, and we're trying a lot harder in Australia to do that as well. So there are some limitations to the guidelines. We only addressed a selected number of PICO questions, and there are other important questions for pulmonary rehabilitation in Australia and New Zealand may not have been answered. Some examples of those are things like the role of self-management. We thought that that was a huge topic. Behavioural change is gigantically difficult, and we didn't address that. We didn't really address the components of exercise training within programs, although there are quite a few studies out there that do talk about the components of exercise training. The role of nutritional supplementation and the inclusion of people with asthma, which was that crossover one that Rob was talking about. At the time we started doing the guidelines, the data around exercise rehabilitation for people with lung cancer wasn't very strong, and we left that one to maybe a future update. There's a lot now even in the last 2 years, there's been a lot more information about that. And we didn't include cystic fibrosis because the model for pulmonary rehab for cystic fibrosis is different because of the problems with cross infection, so we didn't include cystic fibrosis, and we didn't look at the values of repeating pulmonary rehabilitation over time. So in conclusion, we made strong recommendations, not surprisingly, that people with COPD undertake pulmonary rehab to improve exercise capacity and health-related quality of life and avoid hospital admissions. We made weak recommendations about new models of pulmonary rehab that may prompt changes in the way we deliver pulmonary rehab. And I think we need to watch this space. We're working very hard around trying to get more funding for pulmonary rehab because it's effective, and we would need to talk to policymakers and funders to try and show them the economic benefits of pulmonary rehab in reducing hospital admissions and length of stay, so that we can use that health dollar more in providing preventative measures. I'd just like to acknowledge all the people that were involved in writing the guidelines. There were 28 panel members in all. We did have some New Zealanders, and we certainly sent the guidelines to the New Zealand agencies, the cardiorespiratory physiotherapy group, members of TANSIS, etc. So it was widely reviewed before it was published, and I hope it does represent the New Zealand experience as well as the Australian experience. And I think that's it. There we go. Thank you.